Good afternoon, everyone. We're going to go ahead and get started. Thanks for joining today for our immunizations webinar series hosted by the Illinois chapter of the American Academy of Pediatrics. My name is Monica Del Cello, and I'm a senior immunizations manager here at ICAP. We have a pretty solid group today, so thank you so much for taking some time to join us. Today we have Dr. Marielle Fershone with us speaking on the topic of back-to-school immunizations, ensuring children are protected, and tips for navigating exemptions in Illinois. This session is being recorded, and the recording and slides will be posted on our website later today. Please use the Q&A feature to submit questions you may have during the presentation. We won't be unmuting anyone, and we're hoping to have some time to get to some of those questions at the end of the presentation. Next slide, please. Here you can see our continuing medical education accreditation statement. To receive CME, you will need to fill out the evaluation that will be sent to all attendees later today. Even if you're not seeking CME, we encourage you to complete an evaluation and let us know how we did. Next slide. Here you can see our planning committee and presenters. Any disclosures have been mitigated. Next slide, please. And with that, I want to introduce our speaker for today. Dr. Marielle Fershone is an associate professor of pediatrics at Rush Medical College and part of the Pediatric Infectious Diseases Division at Rush Children's Hospital in Chicago. And with that, I'll hand it over to you, Dr. Fershone.
Thank you. How are you doing? It's always weird to see my old haircut, but I may be going back to that haircut soon. So thanks for reminding me. All right, next slide. All right, so today we're going to talk about the importance of childhood and adolescent vaccination, review the current vaccine requirements for students in Illinois, talk about the health, financial, societal benefits of vaccination, as we always do, identify rules pertaining to vaccine exemptions in Illinois, and talk about the current vaccine rates and trends nation and statewide. Next slide. So there's a lot going on right now in vaccines, as many of you know. On May 27th, there was an announcement made on social media about vaccine policy, specifically COVID-19 vaccines not being recommended for healthy children and pregnant women anymore. And then they updated the webpage on May 29th without going through the Advisory Committee on Immunization Practices. And so that left a lot of us very confused about why we'd be skipping over this very important step and a traditional way to have checks and balances in terms of our vaccine policy and make sure that it's evidence-based. And so they moved the recommendation, but Illinois and many other states are upholding the previous ACIP recommendations for COVID-19, and insurance in Illinois is continuing to cover the vaccine for those populations. And it's still in the VFC program for those populations so far. Next slide. Then on June 9th, RFK Jr. fired essentially all the members of ACIP. And for various reasons that did not have any root in truth, such as, they have conflicts of interest that haven't been disclosed, which is something the ACIP has traditionally been very stringent about over the past 10 years. So then he announces 8 new members, including some vaccine critics, including a pediatric infectious disease doctor who, I run in circles with, and who had interesting ideas about COVID during the COVID pandemic, the vaccines and masking, et cetera. So I am worried that the people that he chose might take policy in a direction that's not in the best interest of public health. The June 25th to 26th meeting is scheduled, and the team just let me know that the agenda just came out. And so that has some votes on it, and VFC vote for flu vaccine, I believe. And essentially, the IDPH is so far, Director Vora is holding the line that they will continue to support clinician decision making and continue to stick to the previous ACIP and CDC recommendations. And I know from talking to them and working with them that there is a strong desire to maintain insurance coverage according to the most recent CDC guidelines. Next slide. So we all know there have been not encouraging statistics on vaccine coverage nationally. Since the pandemic, we've been watching this, and certainly there are a few things to be worried about. One thing is the kindergarten vaccine coverage, and that decreased from 95 to 93%. And also polls, in particular this Gallup poll talking about how still a minority of Americans, but a growing minority of Americans saying that vaccines are more dangerous than the diseases that they prevent, which was the ultimate fear of many of us even 10 years ago, was that vaccine preventable diseases would make a comeback, and only then would people remember why we had vaccines in the first place. And it looks like, we're reliving a lot of these outbreaks. The measles outbreak is up to 1,100 cases with 3 deaths. And so we are recalculating the statistics we knew were true for the bad outcomes of vaccine preventable diseases. And I hope that that leads to parents recognizing how dangerous the diseases actually are, and realizing that we are very lucky to have the tools that we have in vaccines to protect our children. And then, fewer Americans are saying that it's important to have their children vaccinated, which is also concerning. Next slide. This is a tool I love to use, and I'm really happy that IDPH has been able to make this a very high quality tool. And it uses the kindergarten coverage that's reported to ISB every year. And you can look at vaccination trends and also exemption trends over time. By vaccine type and location, and community vulnerability indices. Next slide. Vaccine coverage, and we talked about the nation, but the vaccine coverage in Illinois is also decreasing, not quite as much as it is nationwide, but since I started working in public health back in 2015, we were looking at almost a 98% vaccine coverage for measles. And now we're looking at a 95.8% vaccine coverage for measles. Next slide. So we know that vaccines are the most important, most effective public health intervention that we have ever had in history. And that is not an overstatement. And kids born between 1994 and 2003, vaccination will have prevented more than 500 million illnesses, avoided more than 1 million deaths, and saved a ton of money. $3 trillion. We often try to make this financial argument. People don't seem to believe us, or they don't really count healthcare costs and costs to families as important costs. And that is a larger societal problem. But we know that the VFC program has protected these vaccines for children since the early 90s because of a huge measles outbreak that happened across the country. And a lot of kids died. And a lot of kids got subsclerosing panencephalitis after that measles outbreak. And the country decided, we're not going to let this happen anymore. And we have this very successful program that is now, people are trying to chip away at it. And I hope that public opinion will swing back to support programs like this, and recognize the importance of vaccines again. Next slide. So we're going to talk about some exemptions, medical exemptions, McKinney-Vento, religious, philosophical, and then we're going to, I do think it's important for you to realize that the states differ quite a lot in the types of exemptions that are allowed. And so it's nice to compare what Illinois allows to other states, and see, some have a more open exemption policy than we do, and some have a stricter exemption policy. So there is ways for this to move in the state, but we are also not one of the worst offenders when it comes to exemptions. Next slide. So there has been a rise in exemptions nationally. And again, another, not reassuring slide. On the right, if you look at the graph, you're going to see the blue line, that's any exemption. And you can see that it's gone up to about 3%, 3.3% in 2022, 2023, compared to under 2% in 2011. And then you can see the majority of that is non-medical exemptions, the purple line. And at the very bottom, you can see that medical exemption has stayed stable throughout this time. And so the rise in exemptions overall has been driven by non-medical exemptions. We know that states that have easier rules for exemption have more vaccine preventable diseases. Vaccines work, big surprise. And this is, something that we expect to continue to be a trend in states, but again, something that we hope can be turned around through public opinion. Next slide. So I annotated this here so you can see just the number in Illinois that are looking for religious exemptions. And religious exemptions should be based off of the doctrine of that particular religion. And during previous outbreaks, we've listed and collected a lot of information from religious leaders from every religion to counter the sort of generic anti-vaccine thread that people use to request religious exemptions. And that does not seem to be effective in terms of discouraging people getting their doctors to sign religious exemption forms. And so in 2020, there were about 7,500 religious exemptions in Illinois. And this most recent year, there were 18,500. That is a huge difference. More than 10,000 extra religious exemptions. And this has been steadily going up since COVID. So, there are many factors to this. People are tired of vaccines in general. The COVID pandemic really wore people out. It eroded trust in public health. But we know that trust in primary healthcare providers, particularly, is still very high. And so the fact that we're still seeing exemptions means that our providers are signing them. Or they don't feel like fighting about it anymore, or the families are finding a way to get them through specific providers that perhaps charge to get these forms signed. We know that does happen. Or these exemption forms are slipping through the cracks at schools and they're not actually being signed by providers. Next slide. So the AAP has a policy statement on this, and as we all do, the AAP views non-medical exemptions to school-required immunizations as inappropriate for individual, public health, and ethical reasons, and advocates for their elimination. And I think that is an extreme position to some. but to those of us who track vaccine preventable diseases and have to investigate when a child dies, or who have to watch a child die from a vaccine preventable disease in the hospital, this is a position that I agree with. No child should have to die unnecessarily from an illness that is preventable by a free public health intervention. Next slide. So let's talk a little bit about the forms. In Illinois, there is a religious exemption form that the provider who is doing the child health examination form, it has to be the same provider that signs both. So theoretically, someone could come to you and ask you to sign a certificate of religious exemption, but you didn't see that child for their school physical. They're just asking you to sign it. Maybe you don't even know the family. And so you can use this response as an excuse for why you're not comfortable signing it, because it won't be legitimate or accepted by the school anyway, because you are not the one who signed their physical form, the child health exam form. So there's a link to it here, and it's ultimately up to the school officials to decide if the listed objection is valid or not. But by signing this form, you are also claiming that you completed the school physical form, the child health exam form, and you educated the family about the risks and benefits of not being vaccinated with certain vaccines, using, your own personal experiences, using information about vaccine preventable diseases, walking them through what would happen if a case of that vaccine preventable disease was present at any of their child's activities or at school. And that means a lot of lost school time for kids, 21 days if they're exposed to measles and they're not vaccinated. Sometimes even longer for varicella, depending on how long the outbreak goes on. So this is a huge burden for families, and walking through the logistics of that sometimes can convince a certain percentage of these families to change their mind. And then the other important thing, if you do sign this form, is to discuss the options if they decide to vaccinate in the future. You still want to recommend vaccination to keep their child healthy and keep their child safe, even if you're signing this form. You also could give them information for the particular religious objection they have, which often isn't valid according to the church's doctrine. But this is a very long conversation if you do it right. And we want you to do it right. We want you to have the long conversation, because some of these families are going to be on the spectrum of vaccine hesitancy that's in the middle. They might be a movable middle. Okay, they're unlikely to be on the very extreme side. For various reasons, if they're coming to you and asking you to sign this form. Parents that are on the very extreme side will go to providers who they know do this on a regular basis, or who promote that they do not believe in school required vaccines. Next slide. So McKinney-Vento is a very specific situation for doubled up children, children in shelters, living in motels, migratory children, runaways, and lockouts. So these are unhoused children that the school cannot exclude them from coming for a lack of vaccine documentation, because it is so challenging and these kids have so many barriers to vaccination. However, this isn't to say that we shouldn't be vaccinating these populations. We absolutely should. They are at higher risk a lot of times for vaccine preventable diseases, and they should at least be on a catch-up schedule, right? At the health department, we have mobile services and school services that go out specifically to help these kids have access to vaccines. And we need your help too. If you see them in clinic, use any opportunity you can, right? Urgent care, emergency room visits. Anytime you're seeing them, they need to be caught up on their vaccines or start a catch-up schedule. Next slide. So all requirements are state-based. Every state's going to have different requirements. So if you've just come from out of state, you should familiarize yourself with the state legislation, which we'll go through in a second. There's no law. There's no actual law that children must be immunized, but they do have to be sent home during an outbreak. And so many schools, including most public schools, will take this extremely seriously and not allow kids into school if they have not provided the school with the proper documentation. Next slide. So these are the school forms that families may come to you with. Next slide. And the most important one is the certificate of the child's health examination, which there was a new one in January 1st, 2024, that you, after the first of this current year, you may only use this one. Again, enforcement of this rule is going to differ by school system, and but I can assure you that at least for Chicago public schools, that this is an important thing to make sure you're using the most updated form. Next slide. Oh, and just go back 1 second. The other thing that you want to check is talk to your clinic manager about making sure this is the one that's being linked to in your electronic medical record, because a lot of times we don't question, right, what gets printed out after we've input all the information into the chart. You can print the child's examination form now, and you may not know whether that's the right version or not. So you have to have this conversation before the back to school rush starts, which, it starts as soon as school ends. So definitely a conversation to have with your team if you haven't had it already. Next slide. The sports physical form. This is a tricky one. I used to be asked to fill this out a ton, not so much anymore because I'm more of a consultant now than a primary care provider. But the child health examination form can fulfill the sports physical requirement. So in essence, there really shouldn't be kids coming to you needing a sports physical form unless it's in the middle of the year or they're deciding to do a new sport. You should be able to use the child health examination form as the sports physical form. So make sure that make sure that you're asking the family, did you get the full child health examination form? Let's do a full physical. Let's make sure they're up to date on their vaccines, right? Let's do the developmental screening we need to do. Let's not just focus on this one form that they brought us, because that doesn't tell you the whole story about the kid. Next slide. Chicago Public Schools follows the same requirements as the rest of the state. There's a link there for the student health requirements. And October 15th is a very important date that sticks in my mind, because at the health department, we would rush to do as many back to school events as we could before this date, because that is when theoretically CPS could start excluding kids from school based off of not having up-to-date immunizations. And parents were very sensitive to this deadline and very responsive. They would get a letter from the school nurse, typically, that would say what's missing in Aspen, which is the school system that tracks their health information. And during a transition to Aspen, there was a lot of paper records that had to be manually uploaded. But at this point, the nurses really have been more on top of it. It's aligning more closely with what you're actually seeing in the office. But you should be aware that your office may see immunizations that don't look exactly the same as Aspen sees. So if someone comes in with a letter that says, oh, this kid hasn't had chickenpox vaccine, and you're like, yeah, they did. They had it when they were 4, along with the MMR vaccine. All you need to do is print out that record and send it back with the family, and then they can update that in Aspen. That can cause a lot of frustration for families, but it's fixable, and you only have to update it once. They're very good about putting the right information in if provided with it. Next slide. So this is the administrative code that contains the public health code, is Title 77. And it says, what the Department of Public Health does and what the requirements are for vaccination for school. Next slide. An easier way to read this is in a chart like below, which IDPH has put together, and I would suggest going to this resource instead of the legislation. And yeah, you're looking by the antigen that is required. And it walks you through, depending on how old they are, what the requirement is. Where I think this gets confusing for people is that some people think that the state requirements are beyond what the ACIP requires, but it's not. It's typically less in some cases than what the ACIP requires. And depending on what combo vaccines you're using, it sometimes doesn't align exactly. Sometimes you end up getting an extra Hep B because of a certain combo vaccine early on. So as long as you're hitting the minimum for schools, which the ACIP schedule does, then there's no problem. We encourage you to vaccinate with the recommended vaccines, not just the required vaccines, because there are some very important recommended vaccines like HPV to prevent cancer, and flu vaccine every year, especially for high-risk children. Next slide. Pre-kindergarten vaccines, you're just following the ACIP schedule, okay? If you follow the ACIP schedule, you're good. And if kids are coming in and they are behind on their shots, as many are before the age of 2, we really give them until 2 to catch up completely, then you need to catch them up. And as long as they're in the process of catching up, they can't be excluded from school. Next slide. Here's the kindergarten requirements. This is an extremely important one that they take very seriously, mainly because MMR and varicella are on there, as well as your 4th dose of DTaP and polio. So one point I want to pick out here is that a lot of families are asking about early MMR vaccination. And IDPH did send out a Dear Colleague letter to let providers know that the early MMRs for travel to an outbreak state or international was already covered, to get an early vaccine, either between 6 and 11 months, or an early second dose. So the difference between that historical insurance coverage is that now, if someone is traveling to an outbreak state, insurance will coverage an early second dose for that child. And so if they're 3 and coming to you, you're used to giving MMR and varicella at 4, 5, 6 years old. If they're 3 and they're traveling to Gaines County, Texas, where their measles outbreak started, so the epicenter basically of all the measles cases, you're going to want to recommend an early second dose. That is a high risk situation for that child to only go into that situation with only 1 dose of MMR vaccine. So you will start seeing, as we get farther, as we get closer to the school year, you may see more kids come in who have gotten early second doses. As long as it's 28 days, at least 28 days after their first dose, it should be accepted by the school. So don't back off on that. They don't need another second dose. If they've gotten the second dose early, as long as it's 28 days after the first, that is fine, just fine for school. Next slide. Here's your 6th to 12th grade vaccines. Remembering that you're not done once they're in high school, right? You still have to give that second dose of meningococcal vaccine. And there is a pentavalent meningococcal vaccine now that includes the B serotype. So if you're stocking that, that also counts. But meningococcal B vaccine, right, is not the same as meningococcal ACWY, which is the MCV4. ACWY are much more common than the meningococcal B serotype in terms of what circulates in the United States. And so that's why that one is the one that's required for school. Next slide. Here are the recommended vaccines. Hep A, we're giving everyone 2 doses per the ACIP guidelines, and they should get those, by 2 years of age, typically. But you can catch kids up on it later. HPV, to me, is the one that we really need to start revving up again on this because we've lost some ground. And nationally, I think we're at 67% coverage for kids who are up to date on HPV vaccine compared to 98% for Tdap and meningococcal vaccine. The gap is, I'm sorry, not 98, 88. The gap is almost 20 percentile points. It's sad for a vaccine that prevents cancer to have that problem. Next slide. Oh, just go back 1 second. I want to encourage everybody to recommend COVID vaccines the same way that you've been recommending them. No need to change it based off of the politics that's happening. CDC and ACIP is what AAP, the infectious disease societies, is following, and the Vaccine Integrity Project is likely going to be the source of information on what data do we need to review if we are going to change any requirements. And we'll see if that can keep us going in the background as these changes in the ACIP occur. Next slide. I'm not going to go through all of this, but it's nice to have as a reference. And remember that you're giving Tdap, right, when you enter 6th grade, not DTaP. And the difference between those two is there are different amounts of antigen in each. So there's less of the acellular pertussis antigen in the Tdap vaccine and less of the diphtheria antigen. So it's really important for both tetanus and for that pertussis boosting effect per school, because we do see a lot of outbreaks of whooping cough in high school because of their behaviors changing and the types of social circles they run in. Next slide. Here's chickenpox. Next slide. MMR, I think we talked about that one already. Next slide. Oh, actually, go back to the MMR 1 second. I do want to remind folks that if you are giving an early first dose for international travel, that vaccine does have to be made up. We still encourage kids to get 2 doses 28 days apart after the age of 12 months. And that is because your immune response is much better and longer lasting. Eventually we may find better data about maybe being able to do 1 dose, but for now, if the kid has gotten it before 12 months, know that you have to give 2 after 12 months. Next slide. MMRV is a combination vaccine. This is on the agenda, unfortunately, for the ACIP meeting, but there's no vote on it, so I don't expect any changes for this vaccine. Next slide. And this is good for the 2nd dose, as you all know. The 2nd doses of MMR and varicella. Polio, next slide. Haemophilus influenza B, next slide. Invasive pneumococcal disease. One thing I want to point out is that when you're catching kids up for vaccines, if they come to you having missed, their 4 to 6 year old shots or some of their shots for under 2 years old, there is sort of a maximum age for some of these vaccines. So Haemophilus influenza and pneumococcal vaccine, if they're over 5 and they didn't get a full series, then you don't need to catch them up for school. Next slide. And this is something you want to use the CDC tools, the catch-up vaccine table in the 2025 schedule. Keep that handy. The other thing I'd recommend in this time of uncertainty is that you save a PDF version of the CDC immunization schedule with all the tables, because this may be the last time that it is intact and up to date as far as it can be for evidence-based recommendations. And so this needs to be held in your office somewhere, whether it's on your personal computer or whether it's linked in your EMR. But this version may come down at some point, and so we want to keep our hands on this one. Next slide. Meningococcal vaccine we talked about. Next slide. Deadlines, we talked about October 15th being an important marker, but some schools and districts may have their own deadlines. You probably know them because you have to see double the patients before whatever this deadline is in your back to school rush. The reason for the deadline is that the schools have to report to the Illinois State Board of Education what their vaccination rates are. And this is important for us to gauge nationwide how our vaccine coverage is for each state, and then how it's trending nationwide. So students who are not in compliance with the vaccination requirements without an approved exemption shall be excluded from school. Again, this is not law, but this is Illinois State Board of Education recommendation, which you have to be accredited by the Illinois State Board of Education to have your doors open as a school. So this is taken very seriously, obviously, by the schools. Next slide. Immunizations for new arrivals. This area has also been unpredictable lately, but you will keep seeing these patients, and you likely still have patients in your practice that you're catching up on vaccines. But the first visit is going to be, you're going to be getting basic labs, you're going to be getting a trauma-informed history from this family, and you're going to look at any vaccine records that are available. You can only accept written documentation of vaccines with a date in order to say, yes, this child has gotten them, and to put them into eye care. However, families may come to you with verbal reports that someone's up to date. It's never the wrong thing to catch them up on those if you don't have written documentation, because you don't want that kid being kept out of school, and there's no harm to the child by repeating any of the vaccines on the schedule, unless you're worried about it being too soon from a previous verbal report of a vaccine. Back to school visit. Hopefully they come in for the back to school visit with you also. You saw them for the first visit, so you can go over the testing with them. Do they have HIV or not? So you know whether to give live viral vaccines. If they do, what is their CD4 count? Because if it's less than 200, you can't give MMR and varicella, but if it's over 200, you can. And then do you need to revaccinate or catch anybody up? And at this point, you also want to screen them for whether they're housed or not, or what their housing situation is. Are they doubled up, right? Because then they would qualify for the McKinney-Vento exemption. And doubled up meaning that not everyone knows that terminology, meaning that there are, maybe they're staying on the couch of a family that they know, for instance. So there are actually two households or more within one house. Yeah, and then just a reminder that your PPD, which is important for our new arrivals, the PPD, whether or not you're doing the colds or the PPD, you're going to want to have that drawn on the same day or placed on the same day as the MMR. And if you don't, or you forget, you have to wait 28 days after the MMR and varicella because of the immune response to the vaccine, and that, possibly leading to a false read on the PPD. Next slide. So interpreting records, ICAP has some really good resources here about global vaccine schedule comparisons, and looking at vaccine gaps. And again, yeah, just make sure all the dates on the vaccine records make sense. Sometimes the dates will be too close together or at ages that don't make sense for that vaccine. But you also need to check, well, which country were they in when they got these vaccines? And was that the recommendation for that country? Next slide. So policy changes that may come down the pipe that will affect school vaccines would be increasing exemptions for schools, and then removing a requirement to show vaccination records at schools. This would put kids in school at great risk for vaccine preventable diseases if we stopped having documentation collected at the school level. The public health department also wouldn't be able to respond to a vaccine preventable disease being in a school because we wouldn't know who to exclude. And you wouldn't be able to get that information in time to make an appropriate decision and act on it. Okay, so that would disrupt your entire public health infrastructure, and diseases would spread unmitigated, right? So that would be the worst possible scenario, besides our vaccine coverage dipping below herd immunity. Yeah, next slide. Okay, you guys all know this, but we always like to say it. The strength of your recommendation matters. Parents know that if you've been seeing them for a long time, that you care about their child, and they do care what your opinion is on these vaccines. And they can also tell if you are confident in your recommendation or not. If you're giving a weak recommendation, like, you can get it, but it's not that important, right? You never want to say it like that. You say, this is incredibly important to keep John safe. We need to do everything we can to prevent the things that are preventable, because there's so many things in childhood that you can't predict or prevent. And so this is something we can do, and I want to make sure this gets done today. The presumptive approach, right, especially for your adolescent visits, your back to school visits, is saying, all right, Sally's going to get her Tdap, her HPV, and her meningococcal vaccine today, and I'm really excited to protect her against pertussis and cancer and meningitis. Motivational interviewing can tell you where the family is on the vaccine hesitancy spectrum and whether you might have a chance to move them to a yes or a maybe or a let's talk about this again. You can avoid lengthy conversations that won't have an outcome if you judge that they are really on the extreme end. They're really solid in their not getting any vaccines. I'm not going to change that today. You do need to come up with a plan on how you're going to approach it, but maybe that day is not the day to have a long conversation about, the numbers, the number of kids who get exposed to measles who get a certain outcome. And then showing your vaccine confidence around the clinic and with every voice that's coming around in your clinic. This culture of confidence in vaccines and vaccine positivity has a huge impact on families, and it's subconscious, right? But they can tell by what the MAs, are recommending when they walk in the door, what the MAs are talking about, what the conversations they're having. All of this leads to increased vaccination coverage in your clinic. And so think about those little things. Next slide. Remember that there is a school immunization toolkit put out by ICAP. And this is a really nice tool. Next slide. And I'm happy to answer any questions.
Thank you so much, Dr. Frashone. While people put any questions that they might have into the Q&A, Annalise, if you could just go to the next slide quickly. Just want to promote some of our other events that we have. We do have monthly immunizations, webinars, so you can scan the QR code, or we will send out a link in our follow-up email if you're interested in any of those upcoming topics. We also have a number of in-person events throughout the state coming up. Uh, so if you're interested in attending one of our VFC summits, that that link will also bring you to register for those. And we do have a few questions. So someone had an experience with a family that requested an exemption form claiming the kids had been vaccinated in Illinois, but they didn't have access to the records and the kids didn't have any profiles in eye care. So they're just wanting to confirm or get any advice on how to handle families without vaccine records who say the kids are up to date.
Yeah, you're absolutely right. CDC does recommend revaccination and catch up if a family is just giving you a verbal report. That's not going to cut it, especially if there are reasonable ways to get the information. Sometimes you do have to offer to families. Did you contact, did you move from out of state? If so, did you contact the immunization registry or the health department of that state to get a printout of whatever's in that registry? Um, or who was your last pediatrician? I can, request I need you to request the records from them. And then if you bring them in, we don't have to revaccinate. You got to give them that incentive to actually get the documentation. And if for some families, it's a disincentive to revaccinate the children, not for all, but for some families, and that might lead them to also get the documentation. And so you have to be pretty strict about that. And if they say that it was in Illinois, then they should be able to communicate with the clinic and get that documentation. That should not be an excuse. Internationally, sometimes it's a reasonable excuse, but then they're at higher risk for disease and need revaccination.
Perfect. Thanks for that overview. Um, no, this question was there was a type response provided, but just since we have time, could you give another quick overview of the McKinney-Vento exemption?
Yeah, sure. Do you want to go back to that slide with all the examples? The way I think about McKinney-Vento is that it allows vulnerable children based off of their housing status or their housing situation to continue to go to school, right? You're trying to maintain safety for them in the face of this challenge that they have. They are so you the schools continue to let them come whether they're vaccinated or not. That's the McKinney-Vento exemption. So these are the categories of being unhoused or unstably housed that count towards that exemption. So it's essentially any barrier to a child that makes it difficult to have a stable enough day-to-day life that they could easily get vaccinated. And so there are many situations like this for kids and many challenges. And CPS does track the percentage of kids that have the McKinney-Vento exemption from year to year. And a lot of with our new arrival surge, there were a lot of kids entering CPS that had this exemption. But I always like to make the point that these are also the kids. There are some of these populations of kids that need these vaccines even more because they are in congregate settings. They're in a shelter setting. They're in a setting with 10 other families, right? These are kids that it's incredibly important for them to be vaccinated. So when you can safely vaccinate them, that is a priority. But it shouldn't keep them from going to school. And that's what the McKinney-Vento Act protects.
Perfect. Thanks for reviewing that. We have a two-part question from someone who does mobile house calls. So they visit patients in their home and they're wondering how likely would VFC approve this sort of access, and then also any suggestions on how to successfully be a part of the VFC program, which I will just say quickly, any suggestions you have, Dr. Fashon, will be great. I'll also personally message the person who asked this question to get in touch, and we can definitely help support them with that as well. But any other
Yeah,
advice you have
absolutely.
for that question is
Can you read that one more time?
yeah, so this person is a mobile house calls clinic. So they visit patients in their home. How likely would VFC approve this sort of access is their first question, which we might maybe need some more clarity on. And then any suggestions on how to be successfully a part of the VFC program.
Yeah. Um, if you are affiliated with a clinic that is a part of the VFC program, then you can use that vaccine as long as you're following the VFC recommendations for storage and handling of the vaccine in a mobile distribution sense. Because you have to do temperature monitoring in a very different way when you're out on the road with vaccine than when you have it in your handy dandy fridge in the clinic, right? That has an alarm that goes off when the temperature dips or goes too high. Um, so there's specific equipment that you need to qualify for doing mobile events with VFC vaccine. This is federally provided vaccine, so there are strict rules that prevent us from wasting vaccine, but also prevent damage to the vaccine. Because if you have a temperature excursion, if the temperature goes too high, or the temperature, for frozen vaccines, if the temperature goes too low, the vaccine won't work as well. And so in the past, there have been many lots of vaccines that have been lost due to this problem, and many children who have had to be called back for revaccination because a clinic was found to have been giving vaccine that didn't do anything for months. Okay. So, yeah, I mean, the first thing I would recommend is if you're not affiliated with a clinic that has VFC vaccine, you could consider that. If you're independent, then you can register with VFC. And that's depending on if you're in the Chicago area, then it's with Chicago Department of Public Health. If you're outside Chicago, then it's with the Illinois Department of Public Health. And they will walk you through everything you need to become a provider and receive vaccine.
Perfect. Thank you. I will also add as well, for if the person who asked that question has any interest or anyone else has any interest in attending our in-person vaccine summits, those go into some of the details as well about how to get involved in the VFC program, the requirements, as well as some of those details that Dr. Verschoen mentioned about doing like the mobile clinics and everything like that. Um, I'll make one last call for any questions, submissions. We have one more right now, so please, any other questions you might have while we go over this last one. Would it ever be appropriate to offer labs to confirm immune status if there's no shot record?
I'm sure I could come up with a theoretical reason to do that, but also my answer to this question usually is it's not cost effective to do that on a broad scale, and so we discourage it in general. The other problem with that is that with some vaccines, uh, the antibody response isn't the only important immune response that your body makes to the vaccine. And sometimes your antibody response will be, um, what's the word? It'll be intermediate or negative, but you still have T cell mediated memory. And so you're actually fully protected, but your antibody level may be too low. And so that happens with a number of vaccines. And that's why during measles outbreaks, CDC does not recommend checking titers, because if you have documentation of two MMR vaccines, and it's not within the years in the 1960s that they were received, 63 to 67, then that's enough, right? You don't need to check titers, and it could lead to sort of wastage of vaccine. That being said, there's no harm to giving an extra dose of the vaccine if it's 28 days after, their last live viral vaccine. And there are situations, if you're not sure, and the kid is going into a really high risk situation or an event that may have a lot of unvaccinated or sick people, that is a situation that I might decide, yeah, the benefits of giving the vaccine outweigh the risks.
All right. Perfect. It doesn't look like we have any more questions, so we can go ahead and wrap up for today. Thank you so much, everyone, for joining us. I hope you found this webinar helpful. You will receive an email with a link to the slides, to the recording, and the evaluation from us by the end of the day today, so keep an eye out for that. And thank you so much, Dr. Fershone, for taking the time for a great presentation, and we'll be in touch.
Always.
Thanks.
All right, bye.